Hi, good morning, good evening, or good afternoon, wherever you are in the world. Welcome to our Zigvaris Medical Online Hub session. It's a really exciting session today in support of National Self-Care Week in the UK. We've invited Dr. Mohammed Omar El Farouk, vascular consultant, and Stephanie Lohan, who is a leading self-management specialist here within the UK. Today is about talking about the importance of self-care and how to really embed self-care into chronic wound management. Stephanie herself, with this model, has transformed care pathways across the UK for the NHS and reducing unnecessary visits, freeing up clinical capacity, and most important, giving patients and confidence to manage their own health and their conditions. Her model's already been supported by many NHS organisations and changed the lives of countless individuals. So before we get into Stephanie's presentation, I'd really like to invite Dr. Omar to discuss the impact of chronic leg wounds has globally. Over to you, Dr. Omar.
Okay. Yep. Thank you very much, Katie, for a great topic that is near to all doctors all over the world with whatever specialty. And I would like to speak a little bit about chronic wounds and the impact of chronic leg wounds. I think it is what I call a hidden epidemic. The wounds which are found, obviously we must have definition. What is a chronic wound? Chronic wound is a wound that on the allocated time has not healed. So it was not healed by the normal process. Let us say small venous ulcer should heal within 6 weeks. It hasn't healed for 6 months. And this is a definition. We face a lot of wounds in our daily practice. Diabetic wound, ischemic wound, venous ulcer wound, and also autoimmune disease and malignancy and all other types of wounds. And the economic of wound care is staggering. It takes 1 to 2% of population, and it takes amount of funding which is huge. For example, United Kingdom spend 2 billion on wound care. It takes a lot of GDP. In France, it takes 2.6% of French GDP just for wound care. And obviously, we're not spending it really in the allocated time. So why this is increasing? Because we are dealing with an aging population, which the average lifespan is now going to 80 and 85. We have rising epidemic of diabetes. We have every 32nd, one of the amputated leg of a diabetic patient being cut off due to wound management. And we have another epidemic of obesity as well. So all this makes the staggering economic cost. Here I've put course 4 parameters. You can see the global amount of cost spent on just getting wound healed is 250 billion US dollar. That is why this lecture that we are all going to enjoy every second have a lot of importance. I already implemented in my clinic of having self-care. It drains a lot of resources, as you can see, nursing time, equipment time, and this is not necessarily is the best option. Maybe patient, if he was self-managed, he will get better recovery and better shorter time of wound care. And the human cost regarding the quality of life, we know from the quality of life study that unhealed wound have a quality of life as end-stage cancer, end-stage pulmonary cancer. And this is so bad, it affects life, affects the family, affects his social presence, affecting work, affecting a lot of things. So we are speaking about something which is really important to patient life. And let me finish with this nice sentence and nice statistic. Chronic wounds are one of the most underestimated and under-resourced conditions in modern medicine. They are silent epidemic, hidden from public view, but devastating to those who suffer it. And this is the way the future. We should be multifactorial dealing with it. We hope to have artificial intelligence and robotic playing a part, plus the technology, plus our data analysis. The future really have a lot of brilliant ideas. And one of my favorite is this slide, which is a compression wraps that I've already always educate my patient how to use it. And I wouldn't tell you how many patients have thanked me a lot for this device. All the patient, obese patient, difficult to travel, once you teach them only 30 minutes how to use wrap, you can use it easily at home. You can adjust it, you can wash it, you can clean it. It will clear your wound in at least 30% less time than if you go and done a dressing somewhere else. Not only this, but it will cut the cost down to quarter. And this is my usual practice. And this is just an introduction to what will be amazing lecture by Stephanie, which done a lot of work all over United Kingdom. And thank you very much, Kate, for a great idea.
Thank you. Fantastic. I think that really resonates with all of us, doesn't it? You know, globally about the impact it has on our patients and our workforce. So yes, Stephanie, over to you.
Thank you ever so much. So hopefully I can now share my screen and we'll get into implementing self-management. Thank you for that wonderful talk. And absolutely, it resonates with everyone. Anyone on this call, wherever you're hearing from, we know the challenges that we're facing in all of healthcare at this moment in time. So I'm really kind of here today to talk about self-management. So obviously I will emphasize on the wounds, but I want to give it as a whole as well, to kind of, you know, think about all practices within any clinical care. So self-management. Who am I and why am I standing or sitting here? So I am Steffi Lowen, a self-management specialist working across the country in the UK at this moment in time. I say UK, but I've done Ireland as well. Really embedding self-management and teaching and educating teams on how to do that, because it's not as easy as it says on the tin. So the reason why I got to this point was I was the first person in the UK to set up the first self-management team in Leeds, so Yorkshire, if anyone's on the call from that end of the woods. So the first person set up a self-management team in Leeds to really focus on discharging people from caseloads with the empowerment of self-management. And we were soon discharging 133 people every single month on average, which were around 3,000 plus community nursing visits we were saving. As you can imagine, that raised a lot of interest from other organisations around how are you doing it? How can we implement that? Because I've got nursing and psychology, I was able to marry the both together to understand how do we really implement self-management with behaviour change. So as you can see, I always like to share kind of a breakdown of how many different things we were discharging every single month on average. And as you can see, there's so many different things there that, you know, will resonate with you or you may not have even thought about. But I really like to home in on the next slide, which is the wound management and education. So I think community kind of, I'm going to speak about community because that's where I'm from, but if we generally think about insulins and clear-cut things to be able to discharge. However, we get a lot of risk-averse culture when it comes to wound management and education. We don't like to give the responsibility to the individual because we fear around what happens if it breaks down, what happens if something happens. However, I like to share this slide because we've done it successfully, really well in Leeds, and it was always our top discharge. And the stories from the individuals will make you rethink how you think within your current practice. So I think it's just really nice to share that, the fact that it is happening. And since my job in Leeds, and that was 5 years ago, I have now implemented self-management in 58 NHS organisations up to date, which are seeing exactly the same results. What I will say is this isn't an overcomplicated thing. This is something that anybody can do at any time, and the difference is just huge. So what I want you to do now, wherever you are, where you're listening from, is just have a moment to think that you're on a desert island. You are not. I am sorry. Or you may be. um, but I want you to have a moment just to think about you're on a desert island and all you have is a toothbrush. Okay. All you have is that toothbrush. And what I want you to think about is how many uses that toothbrush would have for you on the desert island. Okay. So just have a moment and think, what would you use that toothbrush for? You don't need to put it down anywhere, but just have a minute to think about that. And then I'll kind of tell you some of the response that other people have said as I've traveled the country. So just think, nice sunny desert island, and all you have is that toothbrush. Okay, I'm hoping that you're smiling to yourself. It's really hard when you do virtual because I can't see you, but I'm hoping that you're smiling. And I will share what some people have said across the country as I've done this. So, as I've worked up and down the country, when I do this kind of little bit of the presentation, people have said brushing their hair. I mean, it's going to take a long time. Brushing their teeth, and obvious. Scratching the backs, which is, you know, a very small toothbrush, but you do you. Combing eyebrows and mustaches I've had spearing fish, which I always say you're in the wrong profession if you can spear a fish with a toothbrush. You need to be hand-eye coordinating somewhere. So yeah, as you can imagine, I'm hoping you're giggling. There's a lot of giggles that comes from this. But what I want to really kind of hone in on people is I get you to do this for a laugh, because if you don't laugh about something, you generally don't remember it. But if you laugh, you then remember. So it's that, but also we've all just done self-management in a matter of seconds, wherever you are, wherever you're listening from, okay? We have a tendency within any medical profession, especially within the NHS, to overcomplicate everything. We like to put SOPs, procedures, policies, pathways, everything on top of a model that was created. So therefore, the people that are actually delivering that care forget how to do it or feel overwhelmed to deliver that piece of care because we have put so much red tape above that. So what I try and do with this is say, you've just done self-management in a matter of seconds, and it's all we're talking about is seeing the person behind that clinical task. And that is exactly what you've done with this toothbrush. And I know from experience and where I am that it's so easy to talk about seeing the person behind the clinical task, but in reality, when we have so many visits, call outs, capacity issues, it's really hard to do that. So we do fall into that task focus kind of day. However, what I do want to say is you are human. Wherever you work, whatever you do, whatever challenges you are facing, you are still human. It is okay to think, oh, I don't always see the person behind the clinical task, because you are busy, because you are also human. And this is where I brought in this self-management 4-tier model to really support clinicians in embedding this across the country. Because we are so busy, it is really easy to forget or have guidance on really implementing self-management. Yesterday, I did a case review with an organisation in Yorkshire, and we discharged in one day 195 people from caseloads from community nursing. So I know that we do forget about self-management, but the power of self-management is huge, and the risk is very little if you do it right. So this is the 4-tier model. Very simple. I am very simple. This was created in Leeds by my team. So very much trial and error. So I'm so lucky to sit here now to be able to say, this is what other areas need to do because of our mistakes, our successes. This is what can now be rolled out. So it always starts from the bottom, because you can't build a tower if you don't have a good stable bottom. So the bottom starts that personalised care. Now I know across the country, across the globe, you all know what personalised care is. You wouldn't be in your medical professions, wherever you are, if you didn't want to make a difference. However, I'm not always sure that we get personalised care right, because we've got so many other challenges going on. I'm not sure we always get that 100% right. Let me break this down for you. So this isn't wound focused, but I'm hoping it kind of really gets you thinking. So we worked with a gentleman in Leeds, and he was diagnosed insulin dependent from hospital. So he came home from hospital, 2 community nurses on 3 times a day, insulin. He had a known learning difficulty, so there was a level of risk there. So he came from hospital to community with the support of nurses to give him his insulin. Now, on that initial visit, we went to see him. And if I've got any community staff listening on this call, you never know what's behind that door when it comes to community. So we opened his door, went to greet him, and there was no heating, no light, no food. There was nothing in his house. He did live in a sheltered accommodation, but the warden had said, the person who looks after the sheltered accommodation, he was refusing entry for them to go and check in on him. So we introduced ourselves, and his response was, "I just want to die." Now, I know that that's probably not the first time you hear that. We hear it quite often within healthcare at this moment in time. So I said to him, "Okay, just tell me a little bit about you. Talk to you about how we've got here." And he said to me, "Well, I've come home and they've sent me home with this." And he is waving his insulin pen at me. I said, "Okay. And what about this is making you upset?" And he said, "Well, this pen has to go in my tummy 3 times a day to help the sugars in my blood." So I'm thinking as a clinician, oh my goodness, absolutely. I said, "Yeah, that's exactly right. Perfect." And he said, "But that means I can't go to the day centre to play Star Wars with my friends because I have to wait for you to come put this in my tummy." I said, okay. Well, tell me a little bit more about what the hospital said to you before coming home." And he said they didn't say much. They said that you were going to come in and put it into my tummy. So that conversation around what matters to you, what do you do at home has not happened. We've put him on the pathway because of risk, okay? So I said to him, "Well, what else do you know about this? What else have they given you?" And he picked up a leaflet that we often give out to many of our patients because it's been through every single red tape that we can imagine. Somebody has said that it's safe, so we go and give that leaflet to the person, but unbeknown to us, that person may not understand what we've given them. So he's waving this leaflet at me, and I said, "Okay, tell me a little bit more about this." And he said, "I don't know. I can't read and I can't write, so I don't understand what you've given me." So we're not always checking the understanding of the individual. Now, I know it's always a little bit of a taboo. It still is a taboo. Asking somebody if they can understand something, you find it a little bit awkward, but it's so important we find the understanding of the individual so we can then work with them. So I ripped it up in front of him. I know for the people that are in the UK listening on this call, great use of the NHS money. I know. So anyway, ripped it up and discarded it. And I said, "Well, don't worry about that. You don't need that. But as a clinician, my job now is not to do your insulin, but it's to get you back to that day centre." So we worked with him and really personalised his care. So I'm not on about re-prescribing care. I'm on about personalising care. Anybody at any grade and any level, at any role, has a role responsibility and can personalize anybody's care. We are not changing what's there, we're adapting it for the person to be able to understand. So what we did next was very technical. I'm sure you're going to smile at this. So on the chart where we document when we've given an insulin and what time, we gave that chart to him and we put stickers on it. I know I said it was be technical. We put stickers on this chart. So there's a sunshine sticker for the morning, a ham sandwich sticker for the lunchtime, and a moon sticker for the PM. Because we knew that he couldn't read or write or understand. So why would we continue to try and force him to do that? So we just adapted for him, for his ability to be able to understand it. So we put stickers on that. So we had prompts of when to do his insulin. Now we had 2 insulin pens, not 1, because that would be too simple. So again, we put stickers on the pens. Okay, so we put a sunshine sticker to marry up on the morning one, on his long-acting one, to marry it with the sunshine on his chart, and then a blue sticker throughout the day. We worked with this gentleman for 6 weeks. 6 weeks, that was it. And he was discharged back to the day centre doing the things that he really wanted to do and enjoy. Now, I know, having been in the NHS for 17 years, that if we'd have not really truly personalised that care, that gentleman would still be on our cases now, and we would still be seeing him, and dare I say, he would have deteriorated in his health, mental, physical. We can see it, okay? So the power of personalised care is so important to make sure that you're starting off the self-management journey safely and also effectively. And then you can see next there is a level of behavioural techniques that we do need. Now, I don't expect anybody to be a psychologist. If you are on the call, fantastic. But as nurses, you do not have time to embed all of these things. So I'm going to kind of discuss these behavioural techniques after this slide. And it's some really simple ways to restructure how we do things to stop taking ownership. Because the reason why I brought in this triangle was, especially in the UK, I'm not sure if the rest of the world are the same, but we don't have the individuals that say, don't you worry, nurse, you take a seat. In fact, have a cup of tea. Don't you worry about it. I'm going to take my stockings off. I'm going to wash my legs. I'm going to cream them. And then I'm going to put them back on, all before you've seen me. Unfortunately, we often don't have these individuals. What we do have, unfortunately, is I've paid my taxes. This is your job, not mine. And you're the nurse, so it's your responsibility. And I like to talk about this in depth on the next slide, because I think if we want change to happen and empowerment, we need to be honest and real with who we are seeing and what cohort of patients do we need to kind of do that behavioural change with. Then the next element is thinking outside the box. As you can see, it's a triangle. Do you see what I did there? Actually, I didn't. I just all just fit in triangles. But thinking outside the box is the little bit of the model where you challenge that gold standard of care. Now, I know I've got people sitting on this call thinking, what, Steph? Challenge gold standard of care? Absolutely not. Because everybody's role and responsibility, wherever you are, wherever you're listening from, whatever role you're in, you know your own gold standard of care and why you deliver that, because it's often the best route for the individual. However, there are people out there that do not fit into that gold standard of care, and nor should we want them to. So I'm a firm believer that just because we've created pathways, people don't always have to sit on them. Yes, it needs to be safe, but we need to be able to adapt to people. Okay, our populations are growing all over the country and world, but the way we work within healthcare isn't adapting fast enough. So I think we just need to be mindful when we think outside the box what we are talking about. So again, let me just put this into real life perspective. We had a gentleman in Leeds who came on our books for leg dressings. Bilateral leg dressings, if you ask any TVN out there, any nurse specialist, they absolutely needed that level of compression to support with the weepiness and everything that's going on. They absolutely need that level of compression. However, every single Sunday, this gentleman used to call out and used to say, my leg bandages have come off. I don't know how, but you need to come back and put them back on. I'm sure you're giggling now, some of you, because you'll probably resonate with this. So every Sunday we used to go out and redo these leg dressings. And I said, have we understood the why? Have we understood why this gentleman is taking these dressings off? And they said, of course we have. We've told him if he continues to take down these dressings, his legs will not heal and will have to keep coming in. And I said, well, it sounds to me like you've told that gentleman, but not really understood the why. So they said, oh, actually, no, we haven't. We need to understand the why. I said, go and ask him. So they went back to say, is there a reason? We've noticed a pattern to you taking down these bandages on your legs. Is there a reason as to why? Are they working for you? Are they not working for you? Do you need some help? And he said, well, to be honest, I dress as a woman on a weekend and it's really embarrassing having these dressings on my legs. So what I'm doing is taking them off, putting tights on and being able to go out. Now, what people do in their own lives is not for us to think about, but we are there to support where is needed. So his personalised care, his gold standard of care suddenly changed. Our gold standard of care is that level of compression to aid that healing. But his gold standard of care is to continue to get out to do the things that he would like to do. Therefore, our gold standard is not more than his gold standard. And whilst ever we're pushing ours, we're wasting money, time and resource, but ultimately we're not listening to the individual that we are seeing. So we adapted his care and we got him compression hosiery and I'm getting all blah, blah, blah now. And unbeknown to us and him, he was self-managing within weeks because he had a drive, he had a motivation to self-manage his care. Now, in the UK, I often talk about this, and I'm sure people will giggle. When I talk about people being able to go out and still having community involvement, people say to me, but Steph, if they can get out, they can get to the GP. Now, I know that is the ultimate goal. If you can get out, we should be using GP practice and using what's out there. However, in my experience and across the country, when we have these conversations, we create a housebound individual. If we kind of say, well, if you can get out, we can get to GP, we're not seeing you at home, they tend to then stop doing the things that they like to do because they want us to come in and do that level of care. But actually, if we empowered the individual by using the fact that they go out to take ownership and independence with their clinical task, that they are much more likely to get out of the system rather than just being stuck in the system of healthcare. So it's so important that when we're thinking outside the box, you're not just thinking of that gold standard of care. Yes, I'll always start with that, but make sure that you are understanding the person in front of you. Thinking outside the box, I also love because it really brings in industry, it brings in third sectors, it brings in everybody else. So in the NHS, we often work in silo, okay? We think, oh, anybody outside the NHS is really scary. But actually, without the people outside the NHS and much wider, we will not progress in self-management or adapt or evolve our NHS. We need other people to link in with to be able to really discuss self-management. So I loved it when I was struggling with patients. I reached out to industry to say, what would you suggest? I Googled what else was in my community support with social deprived people. There were so many things out there. If you think outside the box, what could aid you and support with self-management? And then that very last element is that shared decision making and that is where we manage risk, because ultimately we want to know when we discharge somebody or reduce visits, where is the risk and where is the liability and how do we know that we've done it safely? And I'll come back onto that shortly. I'm not going to play this today because I'm trying to fit it all in a short time frame, but I like to just share this if you want to make a note of it. This is the personalised comprehensive care model, which was brought out in 2017 now, and I urge people to go and watch it because it's kind of giving us permission to really go for self-management and embed it and understand it. It's not just some random Yorkshire laugh on a call telling you how to do it. So if you want to make a quick note of it, put it into YouTube or Google and it'll come up. And this was actually published by NHS England in 2017. And it just gives, again, that permission to talk about something to really kind of embed it in your organisations. And it's something that has been around for years and years and years, and we should have been implementing it already. So like I said, on the 4-tier model, there was a kind of the behavioural techniques, which is the bit that I kind of spend a lot of my time with organisations in implementing, because self-management is kind of clear cut. You kind of know, what your goal is as a clinician. It's to get the person independently managing. However, what I will say is the person doesn't have to manage the whole of their care to be self-managing. They can manage, they can do elements of their care, but may not be able to do the whole of their care. That is still self-management. Please do not think about listen to the myths that are out there that if they can't achieve independence, then they can't self-manage. Of course they can. If they can manage elements of that care, it is still a help and is still empowering for the individual. So this is where the behavioural techniques come in. So this is the T-GROW model. I'm not sure if anybody's heard of it out there, but this is a business model because I am not about recreating wheels. I am very much about picking up and adapting. So this is a business model that I've adapted for clinicians. It is called the T-GROW model, and it is simple as this. So the T, it stands for topic. Now, again, in the NHS, if you're going to train staff, you need models, okay? So it looks a bit fancy, but let me break it down for you. So the topic is the conversation that anybody has all day, every day with the patients that they are seeing. So if you're in hospital, in community, in clinic, in GP practice, wherever you're listening, you will say, hello, Jeff, my name's Steph. I've come from community nursing to support with your insulin. Or, hi, Jeff, I'm Steph. You've come to clinic today to have a look at whatever it may be. You will say, hello, my name is, and why you are about to do whatever you're about to do. Because it is instilled in us that we must get consent and understand what is happening, the individual to understand what is happening in that visit. And I absolutely know why we've brought that in and agree with it because it's that consent. However, nobody's thought about the psychology in that very small introduction. And the psychology is you are introducing yourself as a clinician and you are making the clinician and patient scenario, okay? And you are often leading the conversation to be clinical. Now, I know, especially in community, we fear opening the can of worms to talk about something other than their clinical task because we don't have time. But if, again, we do not understand the individual, we are never going to motivate them to be involved with their care. Nobody actually bothered about doing their care. What they are bothered about is how it impacts on their daily living. So the topic is as simple as, instead of going, hello, my name is so whatever, and I'm here to do whatever, it's about saying, hello, I'm Steph, I'm from the community nursing team. How are you today? What have you been up to? Before I talk about anything clinical, because what we are doing is giving permission to the individual to talk about something other than their clinical task. And it is then that they will give you a goal. I'm not sure about the rest of the world, but in the NHS, we love to goal set. Okay, we love to do this goal setting. And again, I understand why we did it and why I brought it out to really push that personalised care agenda. However, if you were to ask me at this very moment in time, Steph, what is your goal? I would say to kind of wrap up and hope that I've made sense to somebody because I find it really awkward doing virtual. But that's not my actual goal, okay? We then ask an individual who's had a long stay in hospital, a brand new diagnosis, a critical condition. We then say to them individuals, what is your goal? It's a very big question to ask somebody in not the right state of, not the right frame of mind. So you will often get a response that is unrealistic and not real to the person. And also, we often get a response that they think we want to hear, and actually it's not at all. So by having a conversation saying, how have you been today? What have you been up to? They will say potentially, oh, I'm okay today. I've not been up to much, but at the weekend I'm off to see my daughter, or I've got my grandkids coming over, or, I'm going to Tesco once a week to have if you don't know what Tesco is, if you're listening in a different country, it's a shopping place. Has a good cup of tea. I'll go there once a week to have a tea with my friend Pat down the road. So as you can see, by asking the individual about just their general life, they are giving me goals left, right and centre. They don't know that, haven't asked for a goal specifically, but by talking to somebody, they give so many goals which we can use to motivate them to be involved with their care. Now, being realistic is always a bit of an awkward one, I feel, because when we start to be realistic with patients, it's because they've probably gone down a rabbit hole. They're probably going somewhere that's unsafe, so we need to bring them back. But let me tell you a secret. Remember when you were a child and your parents, aunts, uncles, teachers, whoever brought you up told you what to do? Do you remember them days? You hated it, okay? You hated being told what to do. As an adult, you still do not grow out of that childlike state. You still hate being told what to do. Okay. And then in the medical field, we often tell a lot of people what to do. And what I'm trying to challenge is stop telling and start asking, because I am sure you do it with your partners and kids, and how I do. If they think it is their idea, they're more than likely to do it. If we've been telling them what to do, they generally won't do it. So being realistic is where we ask them, okay? Let me put this into real life again. We had a gentleman in Leeds who came out of hospital after a triple heart bypass, and we went to go see him for his wound dressing. This gentleman could absolutely self-manage. He was amazing. And I said to him, oh, what was life like before all this? Now, I can hear the clinicians on the call like going, because it's always an awkward question to ask. What was life like before this? Because we know that it was much better than this current situation. But again, if we do not ask that question, we do not know where this person needs to get to or potentially strive to get to. So I said to him, what was life like before this? And he said to me, oh, well, I used to go skydiving. Now, I thought he was taking the mick. So I started giggling. I said, oh, and he said, no, really, I used to go skydiving 4 times a month. And he brought these pictures of him skydiving. So I'm thinking, oh, my goodness, please don't get out of a plane now. Do not jump out of a plane after having this surgery. But remember, whatever we're telling, they're not going to listen and they're not going to be motivated. So I said to him, oh, blummy neck, you're a bit of adrenaline junkie, aren't you? He said, oh, yeah, I love getting my heart pumping. I said, oh, absolutely. What do you think you could do now to get your heart pumping again? Have you thought about what you could do? And he was like, well, probably just walk to end it drive and that'll be enough for me. I said, that sounds like an excellent idea. That sounds perfect. Give it a go and see how much you can get your heart rate up. So in 2 weeks, I rang him to kind of discharge him, make sure everything was all right. And he was able to contact the GP if there's any changes. He was doing fantastic. And I said to him, just out of curiosity, how many times have you ended up at the end of your drive? And he said, don't be daft, nurse. I've ended up back doing full shop and all sorts now. It's been absolutely wonderful and I'm back to where I need to be. Now, if we'd have said to that gentleman, oh, we can't go skydiving, but I tell you what, why don't you walk to the end of your drive and why don't you do some exercises and why don't you do this and we'll give you that and we'll give you this and we'll give you that and we'll give you that. That poor gentleman would have just been snowed under with no empowerment whatsoever because he's been told what to do. Asking the individual, what do you think you could do, is a very different way of asking that question. I'm hoping I'm making sense. And then after being realistic, you need to make sure that you're following your options, thinking outside the box, making sure that if it's not working for the individual, we really kind of think what else could work. Don't just give up. Think what else is out there. Don't be afraid to seek out outside the NHS bubble. And then the way forward is where you look like an alien with 3 heads, which is probably what I look like now. And often when somebody leaves clinic, leaves hospital, you leave their house, you will say, see you later, Jeff. I'll see you tomorrow for whatever. Or see you later, Pat. I'll see you next week for whatever. But what you are doing in that very small amount of time is you, because you are voicing it, taking the ownership out of that environment with you. The person has been left with none. But if we turned around and said, just remember what we're seeing you for tomorrow, Jeff. He'll go, have you had a few bevies in the car? That's a few alcoholic drinks if he's not in Yorkshire. A few bevies in the car because you come every single day for my insulin. Or are you all right because you come every single week to do my stockings? Okay. Oh, yeah, of course we do. You then may look at you and think, oh, they've lost the marbles. But actually, what they have done in that very small moment of time is voiced something around their care. So we have started a very small part of ownership in their brain that starts to grow, because instead of saying nothing, they are now saying something. And this is where we use something called the passing the monkey method. If you have heard of this method and you are still carrying monkeys, question to yourself, why? Okay, so I'm hoping you can see a little square of me. If not, you'll just have to imagine. So we use something called passing the monkey method, which kind of fits into this T-Grow model. So passing the monkey method is where we challenge ownership. This is a very known very well-known psychology model, and you can Google it and read about it if you wish. But it's where we challenge ownership. So passing monkeys is passing ownership. We use monkeys because they jump from tree to tree. They jump from shoulder to shoulder. It is also much easier to think about objects than it is any more terminology. We have enough terminology in our mind that it's much easier to remember an object, okay? So passing the monkey, let me put this into perspective for you. This is where I get a little bit Yorkshire and I have to pretend that I'm an actress. I always wanted to do that, but here we are. So if I was to see a gentleman and I'd said to him, yes, you're going to be able to do your wound dressings. You know, you've said you want to get back fishing. What do you want to do about that? Blah, blah, blah. And he said to me, yes, actually, I do really want to get back fishing. And I think I need to make sure I can get these compression stockings on and off and make sure I'm creaming my legs because I don't want to break down and not be able to go fishing again. Fantastic. He has said that to me on my very last visit to him. So in the next visit I go to check that he's managing to discharge him, I walk into the house and he's sat there and he says to me, oh, nurse, I've had a bit of a headache all week, so I've not actually taken my stockings off. So originally when I left that gentleman, he has got the monkey on his shoulder because he said that he was going to do X, Y, and Z. I have now walked into his house, been really excited to be greeted with the monkey passed on my shoulder because he has said to me, yes, but I've had a really bad headache all week, not the ones where you get your observation kits out, we know the difference. Just the one where he doesn't want to take ownership. So I haven't taken my stockings off all week. So instead of me saying, but Jeff, these are your legs and you need to be able to take these off. And if you want to go fishing, you need to be able to make sure you're managing them. And if you don't manage them, they're going to break down again. I'm going to have to put you back into bandages so you won't be able to get back to fishing. Instead of me saying any of that, because remember, whatever we're telling, they are not listening. It is about me recognizing that he has passed me a monkey, aka ownership, and how I challenge that back. So it's about me saying, oh, Jeff, remember what you said in the last visit though? Why are we working towards getting you into stockings? Boom. I've passed that monkey back. Well, because I want to get back fishing, but I just have a headache. So you're here now, so it'll just be easier if you do it. Boom. Oh, what would you do on a day with a headache that you went fishing? Boom. Well, I'll probably take some paracetamol, but I thought I'd wait for you to come. A lot do that in the UK. But I thought I'd wait for you to come. Boom. Well, I tell you what, why don't you go get your medicines now? I'll get your bits out and we'll work on the next step together. Boom. I'm hoping you can see me and you're not just thinking, why is she on about monkeys and passing? But in this moment, we are doing something called passing the monkey. It is about using the goal of the individual to challenge them. So you are not being mean, but you are creating a behaviour change with something that is personal and emotional to them, if that makes sense. Now, all day, every day, in your personal and work life, you will take monkeys. Okay, so it's all right. We can use passing the monkeys in clinical scenarios, but you also need to be aware of just general life. Okay, this is where I use community nursing, but if you're in hospital, if you're GP practice, wherever you work now, think about how you do it in your organizations too. So let me kind of make this very real. On your day of 999 visits in the community, because that's how many we have, and 7 people have already phoned in sick, it's already Christmas holidays, and you've got 18 call-outs, and you're already drowning. On your first visit, you will go to Pat, and Pat looks at you with the look that only clinicians know. That look where they go, and you go, oh gosh, you're on my first visit. And she'll stand down to me and says, oh, nurse, you know, that heart medication I'm on every single day to keep me alive. And if I don't have it, I'm going to die. I have no more left. And you will say, okay, Pat, I'll task the GP and get you some more medication. What has happened in that very brief introduction and scenario on your first visit of 1999? You have taken a monkey. It seems very small and you think, yep, that's fine, I can do one monkey. But then you go into your second visit and Jeff sat there and Jeff says, I've been on phone to GP for 50 odd years and I can't get through. I can't get any more cream for my legs and they're going to start breaking down. And you go, okay, Jeff, I'll task the GP to get you some more cream. I'm not sure if you can see, but now I have 2 monkeys on my shoulder and I'm only 2 visits in. I've still got 997 left. You then go into handover, which is often a safe place, she says with a giggle. And somebody spins around and says, who's got capacity? Nobody's got capacity. Who's got capacity to be able to take out this pressure relieving? Oh, you're on the same street as this guy. Can you take out this pressure relieving cushion, please? So you add another monkey to your shoulder. Now I have 3, okay? God knows what else I've picked up during the day. And then you go home to whoever was at home, if anybody's at home. But in my house, I get greeted with, Mum, what's for tea? So then I have another monkey on my shoulder. So unbeknown, lo and behold, I have a gorilla. I bleep out the naughty word I normally say. I have a gorilla by the end of the day. So you collect these small monkeys all throughout the day, but by the end of the day, you have a gorilla. And then you've got to outcome this gorilla onto system 1 or any system that you're using without any mistake, because God forbid you to make a mistake in any medical field. It is a nightmare. However, you forget that you are human. Any kind of in the NHS, in any medical area that you're working, if it is not for the frontline staff who are doing the doing, we will not have anything. It is so important that you look after yourselves, who are able to look after the individuals that you see. And this is where I really like to make sure that people are aware of when monkeys have been passed and what that can they do with them. Okay, there are times when you have to take monkeys for clinical risk. And in the training that I do with organizations, we do a lot more in depth around all this. But this is a quick brief oversight. But there's a time when you take them, but you can also shrink them as well. But that when we talk about passing monkeys, it's passing ownership. Think of how many times you've taken a monkey that potentially you did not need to take, okay, and pass it back. There are many times that you probably will do it that you probably haven't even thought about it. Let me just make it a bit of a giggle. So I have a 9-year-old at home. I have a 6-year-old, but she's quite feral, so we just kind of park that one. But I have a 9-year-old, and she says to me every single night, Mum, I say to her every single night, Aria, go brush your teeth. And she says, Mum, no. And I say, Aria, go brush your teeth. And she says, no. And I say, through gritted teeth, Aria, please go brush your teeth. And she says, no. So I say to her, Aria, what do you think is going to happen if you do not brush your teeth? And she says, well, my teeth will fall out. But I've seen these things on TikTok that you can just stick back in there. That is the world we live in now. So then I say to her, Aria, how is it going to make you feel if Mummy continues to get mad with you before bed? And she says, it's going to make me feel sad, Mummy. Okay, Aria, well, what do you think you could do to stop that? And she goes, well, I think I could go brush my teeth. That is a wonderful idea, child. Please go brush your teeth. This is what we are talking about. It is no different to the conversation that you have with your patients. It is about motivating them to think that they are involved in the change and you are not telling. Whatever we're telling, they are not listening. Please try and remember that. If you sit back in your car or go to a nurse's station, reflect on how you have had that conversation. Have you told them or have you asked and empowered them? There is a very big difference. So, to finish, I like to just run over how do we manage the risk with self-management, because as you know, ultimately that is what we want to make sure that we are doing. Okay, we want to make sure that we are doing it well and safely, because I do not want this to be a negative. Self-management is so positive for everybody in any medical field and ultimately the person that we are working with. Okay, so I don't want any errors to happen, so we no longer do it anymore, because it is so powerful and so important that we do. So this is where we use something called that shared decision-making element, okay? So the shared decision-making element only comes in at the very last bit of a patient's self-management journey. So when you're about to discharge or reduce visits, this is where this comes into play, okay? So you'll all know what shared decision-making is, but within self-management, we use it to manage that risk element. So at the end of somebody's journey, you will say, or whilst you're working with somebody, you will say to them their safety advice. You will say, when your leg gets hurt, it turns a bit smelly, it starts to swell, it starts to leak, X, Y, and Z, give us a ring, won't you? You will say that safety advice all day, every day. But what I'm saying is, in the self-management journey, at the very last visit, when you're about to discharge or reduce that person, you have to then stop telling that individual and start asking them. It is about changing that terminology to say, just remind me what you are going to look for and when do you think you might need some further help? Because you will then want to hear from the individual, well, when my leg gets sore, it turns a bit smaller, it starts to swell, it gets a bit more red or a bit more painful, or I'll give you a ring or I'll give the GP a ring. Perfect. Because that is the time, as a clinician, you know that the person has understood and it is safe to discharge. If you were to document, like we do now, safety advice given and patient understood, and something was to go wrong, and you were to end up in court, because everyone goes to the worst case scenario, the question would be, you have documented that the person's understood, but the reality is, where is the understanding of the individual? You've said that they've understood, but there's no clear evidence that person has understood. Whereas if you ask the person and they are telling you, you can then say, individual has voiced their own safety net, which is blah, 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 and their own plan of care, which is blah, blah, blah. And it is so clear then in documentation that the person has voiced that safety net advice and understood what they need to do if something was to start to deteriorate. Now, if somebody looks at you with that fear and goes, oh, I'm not quite sure what I'm going to do, it is not safe to discharge. Go back and think about how you are educating the person on that safety net advice. Again, when I do training with organisations, this is a lot more in depth around how we manage risk. But ultimately, if you are having that conversation and they are voicing to you, there is nothing more clinical than you can add into that conversation. And I'm just going to finish with why are we talking about this. So ultimately, yes, it's saving capacity, it's saving a hell of a lot of money, it's empowering clinicians to actually enjoy work again and make them autonomous decisions around discharge. But the be-all and end-all is the person that we are seeing. So I like to share this lovely lady, Audrey, at the very last of my talks, because I think it really makes you think. So Audrey, she's actually 102 this year. When we worked with her, she was 100. So she was a leg ulcer lady. She went to the GP, knocked a leg on her oven, went to the GP referred us to us because she'd got a leg ulcer. And she was 100. So she went and they went, oh, we can send the district nurse out to come and see you at home. Because she's 100, she's got a leg ulcer. When we went to see this lady, she was an actress back in the day. She's done Disney. Oh my gosh, she's amazing. She used to sing. She's done books and stuff. Every time we went, she was singing, she was doing something, she was fabulous. And within a few weeks, she'd stopped doing that. So when we went to visit her, she'd stopped singing, kind of stopped interacting. And we'd said, oh, we've noticed you're not really singing anymore, or you don't see yourself. And she said, yes, that's because I've not been to my husband's bench in 2 weeks. So she used to go to her husband's bench, who's passed away, every day to sit and have a ham sandwich with him every day. and just share a lunch with him on that bench. She used to walk up the hill to the park. When I say the hill, it was a hill that would have killed me. But she used to walk to that hill, sit on that bench, and share her lunch with a bereaved husband every single day. And we had stopped her doing that because we'd gone in, seen that she was 100, thought we were doing the best care possible, putting that compression on her, but not thinking about what was life like before this. So ultimately, we had stopped this lady going out to something that is so important to her. So I said, okay, well, why have we stopped that? And they said, well, she's 100 and we just thought that she won't be able to get out. Just because someone's age is amazing doesn't mean that they aren't capable to self-manage or get out and do the things that they enjoy. So the team said, oh my goodness, you absolutely still can get to your husband's bench. Please don't think that you have to wait for us. And she said, well, it's embarrassing going out in these big bandages. Is there anything else that can get on my legs? And they went, absolutely. So we changed compression hosiery kit. And again, at 100, she was self-managing. She was going back to the GP for a little dressing changes and reviews. And she was up and out and doing things that she enjoys. We still keep in touch with her because I always have to ask permission to share her story. And she's still managing independently in her own home. She's now put a stair lift in, but she's fabulous. So I think self-management isn't just about us as a workforce, it is ultimately the person that we see, and we can do so much more for the individual if we take a minute and implement self-management. I'm hoping that I have made sense today and you have learned something from this session. Thank you.
Thank you, Stephanie. That was absolutely amazing as always. And I feel so empowered and inspired myself as a nurse. And I've always, the things you say about how important it is to inspire and empower our patients by just having the language, so it's really great. And using the monkeys is an excellent analogy to really understand that. Dr. Omar, did you have any questions? Or would you like me to read the questions from the chat?
I will have a quick question as a start. Thank you very much for amazing lecture, amazing experience. And my question to you, which patient will be suitable for self-management wound dressing? Let us say someone who's obese, 150 kilogram, diabetic, hypertensive, with tremor in his hand. Do you have a criteria which one you can offer him, and what is this criteria?
So I think, thank you for that question. I think that is a common question of who can sit within self-management. So I think it's usually clinical rationale. And sometimes I don't think we use it enough. Sometimes I think because we've got policies and procedures out there, we forget that we have a clinical rationale. You as an amazing doctor will absolutely have that. But it's about looking at the individual and thinking who else is in that circle for that person. Do they have partners? Do they have carers? Do they have somebody else within their own safety net that can also provide that level of care? It doesn't have to be the individual, but it can be their safety net also. Because let's face it, if they're obese, potentially bedbound, with lots of comorbidities, they probably will have carers who will often look at that wound because they're washing and dressing and cleaning up us much more than we ever look at that wound. So actually, clinically, if we can educate the carers or safety net around what they can do, clinically, it's better for the individual because they can look a lot faster at if something starts to deteriorate. They can then reach out to us rather than our weekly reviews or whatever it may be. It's an everyday thing, or they can monitor it. Now, if the individual has nobody else and has a poor dexterity and lots of other things, that's where you use your clinical judgment and think, well, actually, it's safer if we continue with that care. However, doesn't mean that you couldn't advise on other things in their lifestyle that would aid that wound healing. So they might not be able to do the dressing necessarily themselves, but everything else in that may be able to be included in that wound healing. Have I made sense?
Yes, absolutely. Thank you very much. Back to Katie.
Thank you.
Oh, yeah, just got another question from the chat, if that's okay. So do you get much pushback from services, so like management in implementing self-care, and how do you overcome that? Sometimes, because you said, like you said about the policy and procedures, and when management isn't in community nursing higher up, they may not understand. So does that happen to you with your models?
So way back when, 9 years ago, when I was first in Leeds Community Healthcare and I was given the opportunity to do something different, absolutely. I had that challenge every single day, in from senior clinicians, because there was a lot of pushback because of the risk-averse culture we've become. We're so worried about the risk, and we hold on to everything, and actually it's not ours to hold on to. So yes, back then I did have that, but now I've done 50 NHS organisations, and obviously our organisations ask me to come in and support with that self-management embedding. So I don't actually get that pushback from management. And I think we're at the time where we can all see it on the news, especially the NHS, around the changes, the capacity, everything that's happening at the minute. I think now is the right time because people are open to change, and actually people are ready to change. And I always say self-management is the real front line going, whoo, giving a little cheer because it's coming from us. Because if change is going to happen, it's going to come from the front line. It's going to be from the people who actually see the people and can create that change. So I don't get a lot of pushback, but I think what does help is the data of stuff, and being able to evidence the fact that look how much other organizations are doing. There's very little risk, and a lot of the time other policies and procedures are already out there. We've just been so focused on our own task that we forget to look at what else other organizations are doing. So in terms of that, not anymore, but I appreciate back in the day, absolutely, I used to get them left, right and center.
Thank you. Yeah, and we see that with the NHS long-term plan and then the updated Fit for the Future. It's all about prevention. So it's coming from the top and coming from the bottom, and well, not the bottom, but you know what I mean, with from nurses on the ground. So yeah, really empowering, inspiring. Thank you so much. Anybody else have anything left to say? And what
I would like
question?
us to yeah.
Yeah, go on. Yeah, go. Have you got another
Okay, quick
question? Go
question.
ahead.
Yeah, do you think of putting all your valuable experience in a digital format? I'm not sure how many patients you follow up on self-managing. I'm sure it is huge. But is a way, especially with the development of artificial intelligence, with way of have digitalization of wound, this needs this type of dressing. Do you think of converting your vast experience in a digital format, or how do you see the future in this arena?
100% is my answer to that. Absolutely. I think we need to be very mindful of the population, how it's changing. So the population is actually very digital. And at some point, we will be who we're talking about. We will be these patients, and actually we'll be very au fait with digital. And I don't think we utilize it enough. So again, dare I say, in the COVID times, we used a lot of digital. We got a lot of pictures. We assessed phones, and when we suddenly stopped. But we did a lot of work with individuals around taking pictures of their own wounds, sending them to email addresses instead of calling straight out, and doing them reviews. So I really would love to see that if somebody's on that self-care, self-management pathway, we introduce it at that beginning. So if you've had a new surgery and you're in hospital waiting to go home, how do we set it up at that point of discharge with that app? With the education, then you go home, and actually you don't really see anybody until there's an issue, because we in the background we're looking at what's happening, rather than kind of forefronting it and coming in and doing visits at X, Y, and Z when we don't really need to do it. But I'd love to see the involvement of digital.
Thank you very much.
Thank you.
Yeah, great. Okay, well, that concludes our session today. I mean, I think we could all talk about this, forever. So thank you both for joining the call today. It was a great session. Anyone else out there? So this session has been recorded and will be available on MOH, and you'll see everybody's biographies on there too, if you need any further information or support, or want to reach out to any of the speakers on today's MOH. So for that, I would like to say goodbye to you all and thank you for joining.
Thank you so much, everyone. Bye.